You can't replace part of the brain. Like, you
treat them the same.
The source of truth for the medtech industry.
Coexists with the province.
Robot understands things automatically.
Number one show in the medtech industry.
So Stryker got ahead of that and changed in the 90s, built $1 billion company that held up high, a lot of things.
State of MedTech with your host, Omar and Khateeb. Hey everyone. For today's episode, it's a very interesting title, which is Making Sepsis the Number 2 Killer in Hospitals. And why would you want to do that? Every year in the United States, sepsis leads to more deaths than opioid overdoses, prostate cancer, and breast cancer combined. It's the leading cause of death in U.S. hospitals, and many of them are struggling with extremely high rates of sepsis-related deaths in the country, according to the Centers of Disease Control and Prevention. It's a huge issue, and it's probably even worse than we realize because a lot of times sepsis ends up being the final killer to a certain problem that you may face in the hospital and everything. So sometimes it's not even counted. So I think the number is even larger. So to talk about this, I have my friend Dr. Sarma Velamuri to come on the show. He's the founder of a really interesting company called Luminare, who has a very innovative and digitized approach to how do you solve this problem, especially within the confines of the ICU and critical care unit, where you have multiple alarms, you have alarm fatigue. It's a very chaotic environment. And the problem is, as we introduce new innovations and technologies to this part of the hospital, it becomes more difficult, and then it creates its own problems. So Luminare has a very interesting approach to this, and Dr. Velamuri has a fantastic way of thinking about how do we solve this problem. Now, before we get into today's episode, a little shout out to one of our partners, Alpha Sophia. So if you're a startup CEO, a founder, we all know how difficult it is to find early adopters. You can't just Google them, and just looking up on PubMed who published the most, well, that's kind of obvious because everybody is looking at those same people. And so that's where you have to use databases for commercial intelligence. Intelligence such as who's done the most procedures, diagnoses, what societies are a physician a part of. You need data to guide your team. The problem, though, is a lot of these commercial intelligence platforms cost a lot of money for one thing. And the second thing is, well, let's face it, they're really clunky to use. This is why I personally use Alpha Sophia to help with not only my show, but the clients that I work with who are always looking for early adopters. That's pretty much what my company's engaged with, which is commercializing startups to help them find early adopters using social media. We use Alpha Sophia on a daily basis, and you can start using Alpha Sophia right now. All you got to do is go to alphasophia.com/Omar. That's ALPHASOPHIA.com/Omar. You get 3 free reports. So I recommend come with your list or your target list of who you want to look up and give it to the team at Alpha Sophia and have them produce these 3 reports. Not only are you going to see great information on commercial payer information, Medicare, Medicaid, societies, but even contact information. And one of my favorite parts is that I'm able to filter and see which physicians have active social media accounts. So be sure to check that out. And now let's get on to our episode with Dr. Velamuri. Enjoy. Hey, everybody. Welcome back to the show. And we're joined by a guest who I met at the Vive conference, which is a sister conference of HLTH. I was up in Los Angeles. And of course, for that conference, a lot of SaaS companies. And so it was really, everything kind of seemed the same, but this one company kind of stood out, and it's called Luminare. And I'm joined by their CEO and founder, Dr. Sarma Velamuri. Dr. Velamuri, thank you so much for joining us. How are you doing today?
Hey, Omar. Thanks for having me. Please call me Sarma.
Okay, sounds good. Sounds good. So Sarma, let's dive into it. For you guys, you have on your LinkedIn profile page that you're trying to make sepsis the number 2 killer in hospitals. So maybe real quick before we dive into that, but give us a little bit of background about yourself. I know you're a clinician, but now you're a founder. Give us a quick 30-second high level on yourself before we jump into the topic.
Sure. So hi, everyone. I'm Sarma. I like to say, I'm a recovering hospitalist. So I grew up overseas in India, in Bombay, which is now called Mumbai. I did medical school in St. Petersburg, Russia. So I did med school from when I was 17, graduated at 23. Went back home for a couple of years and changed diapers on my grandparents for 2 years. So I have a gap in my resume. And then I got recruited during the match process to the Baylor College of Medicine in Houston, where I did my internal medicine residency and stayed on as an attending physician at Baylor. And here I am in a startup.
Fantastic. So First of all, for the audience, I mean, for me with the clinical background, I know what sepsis is. I'm very familiar with it. But can you give us a sort of simple definition of what should we think about when we think about sepsis, and why is it a big problem?
Yeah, Omar, sepsis is the number one cause of death in a hospital. So sepsis is the body's abnormal response to an infection. That could be a bacterial infection, it could be a viral infection. What's terrifying about sepsis is it can cut down normal people. So folks who don't have any medical problems can still die of sepsis without much warning. And essentially, sepsis is this hidden epidemic that now we're getting more attention around. But one of I think it's fair to call him a mentor, Dr. John Halamkap at the Mayo Clinic, he calls sepsis the final common pathway. Is people die ultimately of sepsis, whether that's a cancer death or it's due to a heart attack. Like a lot of people might recover from the original condition only to get sepsis in the hospital and die from it.
Got it. It makes sense. And, for me, I actually have, I mean, aside from some of the companies I worked at, I have a personal story with sepsis, which was back when I was, I think, 18 or 19 years old. One of my good friends, who's, again, a teenager, had a lot of pain and was going to go over the border. We were living in Texas to see his doctor. And so we decided to go see my father, who's a general surgeon at the time. And my friend ended up having like really, really bad appendicitis, like terrible. And so immediately my dad took him to surgery like that day. And I went, this is back in the time with no vendor credentialing. So I went to the surgery, of course. And I remember my father pulling back the fascial wall and just like a lot of pus coming out, and, learning about sepsis back then, because had he not been operated on that day, it's likely he would have been in critical care the next day because of going into septic shock. So it's a huge issue. What's the current state of sepsis, and how is it being prevented now? Before Luminare introduced. Yeah.
Sure. Yeah. Let me tell you about the current state of sepsis. So about 10 years ago, I worked as an internal medicine doctor in a hospital. So I used to do inpatient internal medicine. I like to call it internal medicine on steroids because we took care of the sickest patients. And I was in a large academic medical center. Very often, the internal medicine doctor, today there's a subspecialty called hospitalist medicine. So I was the hospitalist physician, and I was primary point of contact for all these patients. So no matter how sick they were, where they were, I sort of had to know everything about them. So, patients die of sepsis, right? And so I start complaining about it. So I get appointed to a hospital committee for sepsis. And we installed a large medical record system, went from paper chart to medical record system. We had this idea, look, the medical record system is watching the patient all the time. Why don't we get it to generate an alarm if the patient is developing sepsis? Great idea, right? Sounded like a great idea. The problem is the alarm went off all the time. The nurses hated it. And so then I go, okay, you know what? Like, I wasn't the only person who came up with this alarm idea, but I was sort of, I think, instrumental in implementing it into the workflow. And then I go, wait, let's just give the nurses a checklist on a piece of paper to evaluate why this alarm went off. So the alarm goes off, the nurse runs this checklist, everyone's happy, right? No, nurses hated it. So I'm friends with our nurses, so I didn't tell anyone had anything to do with that checklist because I still had to go to work the next day. And so we're sort of in this thing of like, okay, we've done the best we can. When sepsis suddenly gets personal, I admit my friend's daughter to my ICU, Emily, for a lung and liver transplant. She's 22 years old. I recuse myself from care and I go home for the night because I knew the family so well. I come back one morning, never forget it, like 4:30 in the morning. I walk off the elevator. My friend is standing outside the ICU crying. And there's a code blue event, which means someone's heart stopped. And I rush into the room. The intern and resident are doing chest compressions on my friend's daughter. And, they get tired. I rush in. I help with resuscitation. 45 minutes later, I had to go tell my friend his daughter died of septic shock. And being on the sepsis committee, we obviously looked at, the death and dissected the medical record. Others did. And we said, like, look, we did everything we could for this kid. Nothing else was left to do. And I left that day thinking maybe there was something more we could have done if we thought about it 16 hours ahead of time. And so I hung up the doctor's purse, mortgaged the house, and started a tech company in the garage. And the idea was the alarm is the problem. So artificial intelligence is a great servant, but it's a terrible master. So relying on an alarm to go off telling you that a patient either has sepsis or is getting sepsis is just noise. It's how many alarms go off in an ICU every day? Can you take a guess?
I'm gonna, so only because I worked in that area, but it's something like 30. But I think it's more now because of all the new tech that's come in.
Yeah, it's 30 per what? Per patient per shift.
Oh yeah, that's a good point. Yeah, it's 30 per patient. That's exactly right. So it's just a lot of arms.
Per shift. Yeah. And so I know some hospitals where they've counted, like the chief quality and safety officer of a hospital out in Florida in Jacksonville. She told me that they counted 100,000 alarms going off in a single day. 100,000. So one more alarm going off doesn't work.
Yeah,
so that's the problem with sepsis.
And I think the thing that people have to think about is that when it comes to workflow, like if you imagine just doing work, if you every hour, let's just take one patient, every hour you had, let's say, not even 30, 15 times that some alarm goes off and interrupts you, which means that you have to go and check something even for a few seconds, like you'll never get any work done. And so having all that, we talk about it on social media and the phone, which is switching between different tasks and everything, how bad it is for the brain. Yet clinicians are doing this constantly and they're supposed to be fully optimized to think, correct?
Yeah. Context switching. Exactly right. You couldn't have said it better. There's context switching. There's the alarm fatigue. There is and don't forget the nurses are not taking care of one patient. They're taking care of 5 if they're in a hospital that's staffed, sometimes 6. In the ICU, it can be 2 to 3 patients, sometimes depending upon acuity and how sick the patients are. So and remember, sepsis is the number 1 cause of death in the hospital. It's not heart failure. It's not stroke. It's not cancer. It's not falls. It's not dementia. It's sepsis. More deaths than the next 2 combined, right? And it's happening. Here's the kicker with sepsis. It's happening on our watch. Nobody dies of sepsis without first having some sort of infection that then progresses to sepsis, then progresses to severe sepsis, and then progresses to septic shock. Now, 80% of sepsis cases come in through the door from the emergency room. So these are people who are at home, get infections, either go to their primary care doctor, go to an urgent care center, go to an ER, sometimes get sent back home, and then come back. And now it's gotten a little bit worse. It's progressed from an infection to what I call now as a stage 1 to a stage 2 to a stage 3. Now, for every hour you wait, once the person's blood pressure starts getting soft, which is, what we call severe sepsis, the mortality rate goes up by 10% every hour. Old literature used to say 7%, but it's actually 10%. If you look at that over a period of 3 to 6 months, it's a 10% increased chance of dying. Let me tell you what this means. So if it's 4 a.m. in the hospital and an alarm goes off, shift change takes place at 7. The nurse is busy taking care of some other patient who is actively bleeding to death. Another nurse is taking care of a patient who's had a stroke. This alarm is sitting in the medical record system, waiting for someone to log it. Great. Shift change takes place. Someone clicks on the medical record. Bam. Sepsis alarm. It's been 3 hours. Dismiss. Why? I've had 6 others. That patient was bleeding. The sepsis alarm went off on them as well. Now, this is the least sick patient in the nurse's mind or the doctor's mind or the nurse practitioner's mind, whoever's seen this patient, compared to the other 2. But this person really has sepsis. And so, okay, the alarm went off. I click dismiss. I move on with my day. The nurse is going around handing out medications. There's a code brown. The patients are angry. They have so much to do on their plate. Like they're basically the people taking care of our patients in the hospitals. As much as I like doctors and I like everyone else in the hospital, it falls to the nurse to ultimately deliver care to the patient. And they have so much cognitive load going on. Now, it's 9, remember our case, 4 a.m., earliest time the system detected the person had sepsis. It's not predicting, it's just saying this person's blood pressure is low, they have an infection, something's going on. It's now 9. 5 hours later, blood pressure gets worse because we check the vital signs again and we're going, oh, there's something going on with this patient. Let's go check. How many hours? 5 hours. Mortality goes up 10% per hour. And that brings you your 50% mortality rate. So the VA hospital, they looked at 111,000 patients with sepsis. Omar, guess what the average time to treatment was?
Tell me.
3 to 7 hours.
That's a really long time.
Published in JAMA, 111,000 patients with sepsis. This is, to my knowledge, the only time series study that has been done at that scale. So this problem is pervasive. The VA health systems are pretty tight. They know what they're doing. But it's not a hospital problem. It's a workflow issue. It's you make a better mousetrap. You come out with a better AI alarm that's more accurate, that's more specific, that's more wonderful, and has Mickey Mouse stickers associated with it. Doesn't matter. The well has been poisoned for the last 10 years. And building a better AI alarm doesn't create behavioral change.
Yeah.
That's where we're at today, or we were.
Yeah, no, I completely agree. And I think this is the thing that people forget, which is the influx of all this technology is pretty overwhelming for clinicians, not to mention, especially people forget, like, because they see the influx of technology into places like the surgery and OR and everything. But the ICU is completely different, where it's a mess in the ICU. I mean, there's so many things that are in there, and then adding the alarms to that. So tell us about, like, you started Luminare pretty much by mortgaging your, pulling out a second mortgage on your house and really taking the risk, which I love, because that's how every great entrepreneurial story starts. What does Luminare do, and how does it solve the problem in a new way?
So the problem is not just in the ICU. Yes, the ICU is chaotic, but the problem is everywhere. The problem is people get sepsis at home. They come in the door in the emergency department, and it starts there, sort of like with respect to detection. So I'd like to say the biggest mistake I made was funding my own company, because we've raised just north of 8 million to date through investors who believe in our mission and vision and our business value proposition, which to hospitals is we eliminate sepsis deaths, eliminate inefficiencies. Hospitals become more profitable, generate revenue. What we do is, if you examine sepsis today in a hospital, there's different things hospitals are doing for sepsis. They have sepsis screening, they have AI detection. So that's, sort of let's call it the detection category. Then you have the treatment category, which is nurse talks to a physician, or sometimes they implement a nurse-driven sepsis protocol. The physician turns around, orders the antibiotics. The antibiotics get verified by pharmacy. Antibiotics either exist in the Pyxis or they get shipped to bedside. The nurse then has to go administer these antibiotics, document the administration, and then the physician has to document this accurately. And then enters Medicare, who has come out with rules around sepsis. So you got to make sure you're doing the right thing at the right time. I'm not going to get into whether the rules are the right rules or the wrong rules, but they're rules that exist today. They didn't exist 10 years ago for Medicare. So there's rules around this, and your hospital is getting graded whether or not you've done these 7 things that need to get done for a patient with sepsis. And Medicare has now said, we are going to penalize you if you are a worse performing hospital, if you're in the last sort of like quartile or whatever of the health systems with respect to reporting sepsis outcomes. How much are we going to penalize you? 2%. How much is 2%? Well, glad you asked. For a 125 patient, 125 bed hospital, they probably see anywhere between 600 and 1,000 patients with severe sepsis, septic shock a year. Per patient, they get paid about $25,000, which doesn't even begin to cover the bill. That's 25 million in revenue. 2% of 25 million is around $500,000. So 125 bed hospital is looking at an unbudgeted fine of $500,000 from Medicare next year. So if you're a CFO listening to this is happening right now. You're getting measured right now for reporting next fiscal year, and you're going to get a bill from Medicare next year, basically next fiscal year, for 2% of your sepsis revenues, if you have not hit the quality metric. So you asked me this question, how do you solve it? Well, how you solve it is you don't have point solutions addressing point problems. You create a single solution that addresses all of the problems. And so what we did was we spent years talking to the different stakeholders. We talked to the nurses, we talked to the doctors, we talked to pharmacy, we talked to the CIOs, we talked to the EHR developers, We spoke to the regulatory folks. We got a really, really good understanding about why sepsis is broken. And then we designed a software platform that addresses the whole sepsis problem. That starts with detection. So we have a nurse driven cognitive assistant that's embedded into the medical record system. We have a back end, what we call as a sepsis phenotyping system. So we don't generate sepsis alarms. So from a regulatory perspective, we're not an AI predictive system for sepsis. That's not what we do at all. Instead, what we do is we phenotype sepsis patients using our artificial intelligence systems so that when the nurse is looking at that patient, you can say, hey, Bob, your patient, Sally Mae, Grandma Sally is developing sepsis because she's 82 years old. She has a Foley catheter that, from her hip replacement. You need to check her mental status twice a shift because for her, sepsis is going to look like a change in mental status. It's not going to look like a fever or a heart rate going up. That's what it looks like for a 22-year-old, fever and heart rate going up, right? So that's called a phenotype. So we worked with these folks up in, there's a health system in Rochester called the Mayo Clinic. So Mayo Clinic has a data platform called Mayo Clinic _platform. So we just completed working with them. They have 3.7 million patient records that they've aggregated from different sources. And so when we applied our minds first and our software to the 3.7 million patient records, out came 7 core sepsis phenotypes. And each of these 7 core sepsis phenotypes has 3 subgroups. Now it got interesting because now not only are you able to tell the people at bedside why the patient is getting sepsis, you're able to tell them what to do to prevent it. So every hospital has nurse-driven Foley catheter removal protocols. They don't get used. Why? Hard to know which patient, hard to know the exclusion criteria. And quite frankly, I know it never happens at the hospital that you work at, whoever's in the audience, right, who's listening to this. But sometimes the nurses get yelled at by the providers. Believe it or not, it happens. So they're too scared to sometimes implement or scared or intimidated, whatever word we want to use. But I've had nurses tell me this. It's like, I don't want to implement this protocol because I will get yelled at tomorrow morning. So in that environment, the software really helps the nurses communicate better with the providers and say, look, here's the 5 things going on with the patient. Here's the concern for sepsis. They meet the criteria for Foley removal. We already have an MEC approved, Medical Executive Committee approved protocol for this. Let's take that Foley catheter out. If the provider says, no, you don't know the underlying 3 other things that this person has, great. We help the nurse document that in the chart. And we longitudinally monitor this patient saying, hey, that condition for which you couldn't take the Foley out is no longer true. Take the Foley out. Right. And so that's just one phenotype example, right? That's just one, right? That's just one workflow pathway I walked you through. There are hundreds of these.
Why do you think this problem, because it is a huge problem, right? And, if you talk to anybody, even somebody who's not a hospital administrator, they've heard about how big sepsis is as an issue. Why is it that we haven't seen any innovation? It's 2024, so how come we haven't seen anything like Luminare up until this point? Like, why is that?
Great point, Omar. Why haven't we seen any innovation in this space? I think we've seen a lot of innovation in this space. I have the story of, a young man gets thrown in prison. He's 22 years old. So he digs his way out with a spoon. It took him 12 years to dig his way out. He gets caught 5 minutes after he escapes through the tunnel, gets thrown back in the same cell. And the neighboring prisoner says, I already tried that. He says, why didn't you tell me before I spent because nobody publishes negative results. So in the sepsis arena, there have been lots of people who've tried and failed, and thankfully have been able to talk about why they've failed. So all the innovation, so I stand on the shoulders of giants. So I stand on, all the people who've gone before me who've tried and not succeeded. And so by examining why they failed, we've been able to learn from them, been able to say, here's the approaches that didn't work. And here's exactly the approach that works. Ultimately, sepsis is a behavioral problem in the hospital. Nobody rolls out of bed wanting to ignore their patients to allow them to get sepsis and die. That just doesn't exist. That's not the problem. The problem is that we have so much to do that we're not on top of it. We're not on top of being able to check every patient. It takes too long. So what Luminare has done is said, maybe it just needs to take you 3 to 5 seconds. Maybe the computer does what the computer is best at, which is taking all these pieces of information, putting it together for you in a picture that makes clinical sense so that you can act on it. And then if the right thing doesn't get done because we're busy, because there's a competing priority, we will be able to then rope in someone else from your team to come and help you do this. And if they're busy, we can rope someone else in above them to come in. And if this happens consistently, we know we have a broken workflow. We can tell you why it's broken. We can tell you which shift, where, what time, who the people are, so that we can go back and educate them. You can catch all the people who've done it right and say, can you please come and help our other colleagues understand what you're doing differently from them? Because this is something I've learned recently, Omar. Apparently, all of us have the same amount of time in our day. This was like a
you can't get more
revelation to
time.
me. You can't. It's just I was like, someone said this to me the other day. This because I kept talking about how I don't have time to do this or that. He said, no, stop. All of us have the same amount of time. So maybe you need to play less chess games on chess.com. Maybe you need to watch less TV, but you have the same amount of time. All of that to say that in this noise, right, what we're doing is we're creating stability, a repeatable workflow for the number one cause of death. And when there's deviation from this workflow, the software is tracking it. So the software is the workflow. So when you're not doing the workflow, it gets caught, and it gets caught in real time. And so we have so many stories today. My favorite one is, a chief nursing officer of a critical access hospital emails us. She says, look, my kid's music teacher ended up in my ER, unexplained abdominal pain. Nurse evaluates the patient on Luminare, and the workflow says you should send labs. So she sends labs, and one of the blood tests called a lactate comes back high. Not a great test for sepsis, but if it's up, you gotta look for why. So the physician decides, hey, maybe worthwhile starting antibiotics, looking a little deeper. They start antibiotics. She ends up needing to go to another major medical center. 3 days later, the leadership of this medical center emails our chief nursing officer saying she had sepsis, she had a perforated bowel, just like your friend whose story you talked about with the appendicitis, but wasn't very obvious because her presentation was atypical. But covering her with antibiotics while we were looking for the why is the thing that saved her life. And here's the kicker. They said if she came to us, we would have not thought of sepsis. This lady has now gone back to teaching piano and drums in high school. She has 2 kids. And that story right there is the reason I started the company.
That's phenomenal.
Because we have hundreds of these kind of stories now where the nurse walks up and gives our customer success rep a hug in the hospital saying, I got to tell you about this case yesterday that, we didn't have the labs yet. We didn't have this. We didn't have that. But the back of my mind, I was thinking sepsis. I pulled up Luminare. I checked this patient based on the workflow, and bam, they spiked a fever 6 hours later after we started antibiotics. So we're basically moving detection to the clinical suspicion stage where, the experienced or the inexperienced provider at bedside is able to intervene and not wait for an alarm to go off somewhere.
That's phenomenal. That's phenomenal. So now that you guys, you've raised a decent amount of funding and everything, I know that you guys had an exciting news. You announced a partnership with Cedars, and you have other partnerships. What has been, I guess, your guys' main approach to driving adoption of the technology? Because this is the other thing is that hospitals are more cash strapped than ever these days, and so getting into hospitals has become more difficult. So how are you and your team approaching that?
Great. You hit the nail on the head. Hospitals are cash strapped, and that's how we approach it. So the number one reason hospitals are hemorrhaging money is excess hospital days. So what does that mean? It means we're running at capacity. Why are you running at capacity? Well, we don't have enough people to take care of the patients. Okay. So the number one cause driving preventable ICU stays and preventable inpatient stays, 8% of it is, guess what? Sepsis. And so if I decrease ICU length of stay by 28%, is that meaningful to you? If I decrease ventilator use by 24%, is that meaningful? If I get the patient out,
Major cost savings. And I think this is the thing that hospitals, I think CFOs need to get more savvy about, which is the obvious thing I think for hospitals is like, hey, let's just bring in more patients and more business. But there's a limit to that. You have to find other ways to improve your like operating income and everything. And I think controlling sepsis is one of them.
And I have a lot of hospital CFO friends, and they you know, they care about the patient as much as anyone else in the hospital cares about the patient. And their jobs is to make sure the hospital is financially secure in order to pay everybody who works there so that we can keep our doors open. I don't know, I'm sure you've seen in rural America, like a lot of hospitals have had to shutter because of financial instability, right? And I have a passion for rural hospitals, by the way, because they're the front door to care for a lot of people. And so using software to make it more efficient and community hospitals, don't get me wrong, I love our big academic medical center, all 128 of them. But real care, takes place in the academic medical center all the way through to the critical access hospitals out in 2 hours outside the big medical centers, right? The point being, what we're saying is, look, 8% of your cost today, the number one driver of the cash hemorrhage is sepsis. We think of sepsis differently from every other company thinks of sepsis. We don't think of sepsis. When you say sepsis, people think infection. When you say sepsis, people say predictive alarm. When you say sepsis, people say, oh, here's another company that just got FDA approved for their algorithm. We don't think of sepsis as an algorithm. We think of sepsis as people taking care of people, and that's a workflow. And if you can optimize this workflow using software, you have solved the problem. And so that's what we did. Yes, we use AI. We don't use it to set off alarms, but it's a tool in our box. We had to build an AI tool in order to solve the problem, in order to be able to discover phenotypes in a database of 3.7 million people, right? So in order to solve the problem, the way we approach the hospital is we say, look, do you have an ICU length of stay issue? Would you like to improve throughput and capacity? Would you like less people to die in your hospital? The number one cause of death in the hospital today is sepsis. Yes, there's $0 values associated. I mean, I don't get credit for mortality. I don't get any credit for, I'm not even making mortality claims, by the way, to be clear. I am not saying plug in Luminare mortality goes down. I'm saying plug in Luminare, use the workflow that you already know that you want to accomplish, and you will decrease mortality. It is not the product decreasing mortality. It is your people getting faster, taking care of people faster, and not dropping the ball as often because we are giving them the tools they need to take care of patients. So number one, decrease ICU length of stay. Number two is improve throughput through this decreased ICU length of stay. There's a measurable financial impact. Let me tell you how much. Cedars-Sinai in Los Angeles. So there's a white paper that Mr. David Wrigley, their CFO, wrote about their use of Luminare. The data has been third-party audited by a company called TTI Research Analytics. And this white paper basically says when they deployed this workflow solution in the emergency department at Cedars in Los Angeles, they got 862 ICU beds back in 5 months. That translated to $11.2 million in revenue in 5 months.
That's phenomenal. Yeah, I was going to say this. It's a lot of beds. It's a lot of beds. That's the other thing that people don't consider, which is availability.
So we increase availability, we increase throughput. It makes people's life easier to take care of the patient. The patient gets to survive, not have as many amputations, not have as many days on a ventilator, not have as many deaths. We decrease the body count in the morgue. So the way we engage with the hospital is we say, look, you can become more efficient with what you have today and prevent losses. And then there's a revenue portion to it now. So like I said, Medicare is going to penalize hospitals. Or it's here. They've decided they're doing it. I don't get to decide what those rules are. There are rules. We can make you get better at that. The average compliance today in the United States on this Medicare rule on sepsis, bundle compliance is what it's called. It's about 60%. That means 6 out of 10 patients get fast. 4 out of 10 fail. Those 4 out of 10, when you have 1,000 patients per year with sepsis, when you're a 112-bed hospital, that's $500,000 cash you're going to have to pay back to the insurers. and private payers are going to catch up with this. So ultimately, you fix sepsis, that's the hardest one. Then you could go after heart failure, same approach. You could go after stroke, same approach. You can go after maternal fetal medicine. Did you know that one of the preventable causes for NICU days, babies in the neonatal ICU, is we gave the mom too much. I'm not an expert at this, just based on what my colleagues tell me at some hospitals. We gave the mom too much oxytocin during labor, so the baby came out too fast, had a low APGAR score, and so baby didn't look that good when he or she was born, and so we put him in the NICU for observation. You just fix L&D, labor and delivery workflows. Guess what? NICU days go down. How do you fix labor and delivery workflow? Well, you have a standardized way today. It's not being used by anyone. And so the software helps you. So this approach is a platform. Luminare is a platform. And we sell different blades to the hospital. So we want our customers to solve clinical problems, make money so that we can go back and solve the next problem with them.
So what I like about this, which is very unique, is that it's more workflow innovation than anything, right? And I think that this essentially finds a more creative way to, again, increase the hospital's operating income, reduce expenses, etc. Versus right now, I think a lot. I mean, there's nothing wrong with this, but there's a lot of med tech innovation. But usually, it's adding a new device or new technology, which is there's nothing wrong to it. But again, I don't hear too many people focusing on workflow innovation, which I think is really key. That's what a lot of these hospitals need. For just, I don't know if you have a standard answer for this, but just what does it cost for a hospital, roughly? So something that I really like about your guys' website, which I don't think I've ever seen this for a medtech company, but I love, is that you actually have a tab on pricing. You don't list the pricing because obviously it's going to be different for each hospital, but you actually have 3 different offerings, that sort of lay out the pricing. But roughly, what can a hospital expect when it comes to pricing?
Well, like you said, it's SaaS. So we have a software as a subscription business model. The cost depends upon your patient volumes. So before we start giving you a price, what we do is we try to get an understanding of your problem. It's how much opportunity really is there and how much lift can we produce for you. And what we want to show our customers is a break even within the first 3 to 5 months. And sometimes people hear this and they go you're not charging enough. We go, yeah, we know that. We know we're not charging enough. The thing that we care about is we want our customers to have better patient outcomes, and we want our customers to have better margins so that we can go fix. If our customers don't exist in business anymore, we don't have a business, and there's a lot of sick people who die. So ultimately, we want to take sepsis away from being the number 1 killer in a hospital. And the financial health of our customer is directly tied to that mission. So the way we price this is we have, a pricing model on a per patient per day, depending upon, what portions of our product they're using. Are they only using
pay per use or pay per click?
Yeah, pretty much. And so what we do is we tell the hospital, tell us what your last year's volume is. We're not going to nickel and dime you. This is how much it's going to cost in the next year, so you can budget for it. If your volume goes up by 20%, which is what we expect it will go up by, the next year you're going to look at this kind of bill. But it's very predictable. And oh, by the way, CFOs love this. Oh, by the way, if I don't hit these metrics, you're going to pay me. It's we have a base installation fee, which basically covers our costs. We have a fee on top of that. That's a subscription fee. And depending again on the size of the hospital, we have different models where we can say if we don't hit these numbers, you don't have to pay us. But if we hit these numbers, there's a bonus that goes with it. And so we are happy to be judged by our performance because quite frankly, I served on the value-based purchasing committee for a large health system. Sat on the other side of the table with vendors selling products. I always liked it when someone said, I'm going to solve your problem. I'm happy to put my money where my mouth is for the first year and prove this to you.
Yeah, I think that goes a long way with hospitals. I really love that because I think, again, the key to every medtech company, I think early on is having a very innovative approach to not only attract early adopters, but the other side of it is how do you make it easy for somebody to adopt the product? I don't think that starts by giving the product away for free, but I think finding very innovative ways where, I think that's in in the info product world, it's kind of like a platinum guarantee that you give to a hospital that you just described. And I really like that a lot because most CFOs, I don't know, I'm a big fan. If you're able to get somebody's attention, that's persuasion, right? And most CFOs aren't used to hearing that.
Yeah, that's a great point. And that's exactly why we have this model, is because we listen to our customers. Like CFOs have told us, look, I want to do business with you, but you got to be able to de-risk this decision for me. One CFO told me, this needs to turn into a no-brainer decision for me, and you're making it one. Like to ask the question, why would I not do this? Like if these guys are even like 50% right.
Yeah, and I think that's the key, right, is to make it a no-brainer decision for the CFO, because I think the CFO and the CEO of these hospitals, they're being scrutinized on their purchases and where they're spending money. And again, like if you can't bring in more money, you can't just like manufacture more patients out of the blue, right? The next thing is like, well, how do you control costs? How do you free up more beds? How do you improve workflows? And so I really like that. Sarma, I really appreciate you coming on the show. Just real quick, where can people find you online?
They can find me on LinkedIn. So linkedin.com/Sarma Velamuri. I have a Twitter presence, or X presence, I guess. Sarma.
I still call it Twitter. I can't call it X.
Twitter, yeah. So I have a Twitter presence. I haven't posted on it. I live under a rock. My primary mission is, building a successful enterprise to stop a very large problem. So you won't find me on social media except for LinkedIn. So LinkedIn is kind of the money shot. If you want to get hold of me, you can also email me, sarma@luminare.io. Unless you're a customer, I don't guarantee you a response within 24 hours, but I will reply to your email if you send it to me. And it's a consequence of I just learned that I have the same amount of time as anyone else in the world. So all of my time currently is spent in taking our company to the next milestone.
Fantastic. Yeah, and for those who are listening, if you want to learn more, go to luminare.io. That's LUMINARE.io. So, Sarma, thank you so much for coming on the show. I'm looking forward to having you back in the future with updates. I'm your host, Omar Khateeb. This has been another episode of the State of MedTech, and we'll see you all next time.
Thanks for checking out this episode. If you want to do me a big favor and join so many other people who have helped grow this podcast, take a second and look below. If you're on Apple, give us 5 stars and write a short review. If you're on Spotify, just give us 5 stars. And if you're on YouTube, hit the like button. And most importantly, if you can, subscribe. We release so many different episodes that you may miss. Be sure to subscribe and turn your notifications on. You get extra points with me if you subscribe across all 3 channels. Thank you so much. And if you felt like this episode helped you, send this to somebody who'd really enjoy and appreciate it. Share and spread the love. We'll see you all next time.